Hello everybody, this is Dr. Tilak from the Department of General Medicine, Medicity. Today I'll be discussing an important topic from neurology, and that is extrapyramidal disorders, and one of these disorders is Parkinson disease. So I'll tell you what the Parkinson disease or Parkinsonism is all about, what are the clinical features, any investigation to be done, and how to treat. So let us start with the discussion of extrapyramidal disorder, that is Parkinson disease. So basically, Parkinson disease is a degenerative disorder. It is not because of some infection or inflammation or demyelination or tumor. It is basically because of degeneration of neurons in some part of the nervous system, central nervous system primarily, and subsequently other parts of the nervous system are also affected. So it is quite common, only next to Alzheimer's disease. And all over the world, if you look, large number of people suffer. Nearly 5 million people will be suffering because of Parkinson disease at any point of time. Most of the time, this degenerative disorder, Parkinson disease, is seen in people who are above 60 years of age. Though it may be seen earlier also, as early as third decade also. But then it is likely to be due to some other reasons. There may be some etiology or some familial predisposition. And with increasing age, there will be more chances of people to be affected with this condition. So frequency of Parkinson disease will increase with increasing age. So what is the basic pathology? It's, as I mentioned, there is a degeneration of the neurons in the nervous system, primarily in the central nervous system and later on peripheral nervous system as well. So mainly it affects the dopaminergic neurons in the basal ganglia. So all parts of the basal ganglia may be affected, but most important part of the basal ganglia which is affected in Parkinson disease is substantia nigra. Okay, and because of this degeneration of these neurons, there will be less synthesis or availability of dopamine, and that will result in various clinical manifestations. And subsequently, because of degeneration, there will be presence of certain proteins in the affected neurons called Lewy bodies. So it is not just the involvement of the basal ganglia in patients with Parkinson disease. Other parts of the nervous system are also affected, like nucleus basalis or locus ceruleus and raphe nuclei of the brainstem. And subsequently, other parts of the nervous system, as I mentioned, peripheral nervous system may also be affected, like the olfactory system may be affected, spinal cord may also be affected, and subsequently in the latter part of the Parkinson disease, there will be involvement of the autonomic nervous system with various clinical features. So, as I mentioned, it is not just involvement of the basal ganglia, but other parts of the nervous system are affected. So, the disease may affect the peripheral nervous system, olfactory system also, and also the some cranial nerves, especially vagus nerve. So, it is not restricted to the basal ganglia only. So, with the increasing duration of the disease, other parts of the nervous system get affected by this degenerative disorder of the nervous system. So before I go into the clinical features of Parkinson disease, first we should know what is the meaning of Parkinsonism. See, Parkinsonism is not synonymous with Parkinson disease. Parkinsonism basically is the symptom complex. What are the manifestations? First, you should define what the manifestations are there, and based on that, what syndrome is there because of these manifestations. Like in case of meningitis, meningism is not synonymous with infective pathology of the meninges. So meningism is one thing and etiology is secondary. Similarly, Parkinsonism does not mean Parkinson disease. So let us first look at what the meaning of Parkinsonism is. So when a patient has got these manifestations in the clinical picture of the patient, these manifestations are features of the syndrome complex called Parkinsonism. Okay, so the most important features are tremors, which are are at rest only, and second is bradykinesia, which means slowness of various motor activity, and there will be increase in tone of various parts of the body. It may affect any muscle in the body, and it may be symmetrical or asymmetrical depending upon the type of Parkinsonism. In Parkinson disease, the manifestations are asymmetric. In other, it is likely to be bilateral symmetrical. And then various postural reflexes are lost in Parkinsonism, like when we get up from sitting position, or when we are walking, or when we are turning side, etc. So lot of postural reflexes work at subconscious level. So if these reflexes are lost, the patient will have instability while getting up or while walking. And because of the tone abnormality in various muscles, there will be a change in the posture of the body, especially when the person is standing or walking. And another feature is freezing. Freezing means when the person is walking or doing some work, especially while walking, the person will be walking slowly, and suddenly the feet will stop walking. The upper part of the body will remain in motion. So as a result, what will happen? The person is walking, feet stop, and the upper part of the body is walking, moving. So there may be a fall forward because suddenly the feet will freeze to the floor. So this is called motor block of freezing. So all these features, when present, they constitute Parkinsonism. But all these features may not be present in a given patient. Then how do we say patient has got Parkinsonism or not? So these two, tremor at rest and bradykinesia, these two are most important. If these two are present, you can make a diagnosis, definitive diagnosis of Parkinsonism. If one of these is present, then you have to take two from these four to make a possible diagnosis of Parkinsonism. If both tremor at rest and bradykinesia are absent, then all these four should be present to make a possible probable diagnosis of Parkinsonism. So all features may not be there, especially in the early phase of the disease. So this is just a graphic representation of various manifestations of the Parkinsonism or Parkinson disease. So bradykinesia, you ask the patient to move any part of the body, whether it is hand or feet or any other part. So there will be movement will be there, but the movement will be slow, called bradykinesia. And then because of increase in the tone, there will be hypertonia, and this hypertonia is different from spasticity. So this hypertonia is rigidity type. Rigidity means there will be increase in tone in both gravity or anti-gravity muscles, or flexors and extensor group of muscle at the same time. And because of superimposition of tremors with the hypertonia, there will be cogwheel type of rigidity or lead pipe type of rigidity. And tremors may be there. These tremors may affect any part of the body, upper limb, lower limb, neck, etc. And then the gait will be characteristic of Parkinsonism. The patient will have shuffling gait. What happens in shuffling gait? The person will move slowly, and he will not lift the foot off the ground as much as normal people do. So it will be like he's just shuffling the feet along the surface. And then various features like expressions from the face may disappear, what is called mask-like expression. And as I mentioned, there may be loss of postural stability, or reflexes may be lost. So while standing, while walking, while turning, the person may not be able to maintain the balance of the body and may fall in any direction, forward or backward. So as I mentioned, primarily there is involvement of the basal ganglia in Parkinson disease or Parkinsonism. So what are the structures included in the definition of basal ganglia? So there are various parts of the central nervous system which constitute what is called basal ganglia. So the important components of basal ganglia is striatum. Striatum is basically when you include putamen and caudate nucleus together. Okay. Another part is the subthalamic nucleus. And other parts of the basal ganglia are globus pallidus. It has got two parts, external part and internal part. And as I mentioned, the most important part in the development of Parkinson disease is the substantia nigra. So this is also an important part of basal ganglia. Thalamus is not included in the definition of basal ganglia. So this is a graphic representation of various parts of the basal ganglia. So by the side of the lateral ventricle, this is caudate nucleus, and this is putamen, globus pallidus. And in the brainstem there will be substantia nigra. So these are parts of the basal ganglia. If you take a cut section of the brain, the same features will be visible, like caudate nucleus, putamen, globus pallidus. And if you look at the brainstem, midbrain, there will be substantia nigra. And if you do MRI, same structures will be visible: caudate,
putamen. Globus pallidus is more medially, and in the lower parts of the brain you will see substantia nigra or subthalamic nucleus. So this is a cut at the level of midbrain. If you see this little gray structure here, this is substantia nigra, very important. So when there is involvement, there will be various manifestations of Parkinsonism. So these structures, as I mentioned, these structures occupy a lot of space in the brain. So what functions do these basal ganglia perform? So what is the basic role of the basal ganglia in the normal functioning of the central nervous system? So on their own, they don't do any work, but whatever the work of other parts of the brain, they modify that. So basal ganglia have got connection with virtually with every part of the central nervous system. So they have got some feedback, positive or negative, with other parts of the brain. So they basically modulate the functioning or modulate the effects of functions of other parts of the brain. So basically, like motor behavior, when we are doing any work, whenever we are using muscles, what is the speed, what is the tone, any abnormal involuntary movements are coming or not, that regulation is carried out by the basal ganglia. Motor activity depends upon the motor cortex of the brain or corticospinal tract or motor neurons in the spinal cord, but this activity is normal or not, that is regulated by the basal ganglia. Similarly, emotions do not depend on the temporal lobe or the frontal lobe alone. The regulation of emotion or reaction to anything is again modulated by basal ganglia. So whenever there is involvement of basal ganglia in any disease process, there will be some emotional abnormalities also. Cognitive part, as we know, it depends upon the frontal lobe. But frontal lobe will not work alone until it has got some positive or negative interaction with the basal ganglia. So cognitive functions of the brain are also dependent upon modulation by the basal ganglia. So basically, basal ganglia regulate or modulate the functions of other parts of the brain, including motor activity, emotions, or cognitive functions. In the basal ganglia, there are basically supposed to be two pathways. One is the direct pathway and one is the indirect pathway. So they have got different many effects on the thalamus and then subsequently on the motor activity. So whenever there is normally there is a balance between direct and indirect pathway. If this balance is lost, there will be various manifestations. Either the motor activity will be less, like bradykinesia may be there, or motor manifestations may be more, like tone may go up or tremors may come. So this balance is required for normal motor functioning of the body. So if a patient has developed, now we come to the Parkinson disease. So this discussion will be about Parkinson disease, not about Parkinsonism. Parkinsonism, I have already told that bradykinesia, tremors, rigidity, etc. Those things constitute what is called Parkinsonism. The next point is, what is the cause of Parkinsonism in a given patient? So Parkinsonism may be because of no known etiology. If it is idiopathic without any etiology, then it is called Parkinson disease. So patient has got Parkinsonism and there is no etiology and there are no other dysfunctions of other parts of the brain, then it is Parkinson disease. If the patient has got Parkinsonism and there is an etiology, then it is called secondary Parkinsonism. If a patient has got Parkinsonism and there is associated dysfunction of other parts of the brain, like dysfunction of the brainstem or dysfunction of the cerebellum, etc., then it's called Parkinsonism plus, like MSA or multisystem atrophy. So today I'll be discussing Parkinsonism, which is because of Parkinson disease, which means a patient has got dysfunction of the basal ganglia and there is no etiology, only primary degeneration of the neurons in the basal ganglia called Parkinson disease. So broadly, we can categorize the manifestations of Parkinson disease as cardinal features or most important features, which are present in most of the patients, and some other less often seen motor features and some non-motor features like autonomic dysfunction or sleep abnormalities. So if you come at the chief manifestations of Parkinson disease, most commonly seen in almost all the patients, as I mentioned, one is the bradykinesia or slowness of movements and rest tremors. So these two are very important to make the diagnosis. And tremors are at rest, not while doing some motor activity. Suppose a person is keeping the hand on the table, for example, there will be pill rolling type of movement of the thumb and other fingers also.
And if the person moves the hand, the tremor will disappear, and in the new position of the hand, tremor will reappear after a short delay. And also there will be hypertonia of rigidity type. And gait disturbances, as I mentioned, there will be short shuffling gait will be there, slow movement will be there, and in the later part of the disease, patient will have various postural abnormalities, like while getting up from the sitting position or while walking, the person will tend to fall or may actually fall because of loss of postural reflexes, resulting in postural instability. So this is just to show what bradykinesia is there. Person will not have any paralysis. There is no paralysis. All the movements will be there, but the movements will be slow. The movement may be related to upper limb, lower limb, or writing something or speaking something. So there is slowness of movements of various parts of the body. Important thing is that the manifestations of Parkinson's disease are mostly asymmetrical, even in the later or advanced stage of the Parkinson disease. And if there is a symmetrical manifestation, then you should doubt the diagnosis of Parkinson disease. Other manifestation is rigidity or hypertonia. In this hypertonia of Parkinson disease or Parkinsonism, there is increased tone in both the agonist and antagonist group of muscles, like flexors and extensors of the elbow. There will be rigidity. So the movements will be slow. One is because of bradykinesia, and second because of hypertonia. And there is, when the hypertonia is associated with tremors, then as you try to move the limb passively, there will be jerky movement, what is called cogwheel type of rigidity. And in some cases the cogwheel type of rigidity is not there, only there is continuous same resistance to passive movement called lead type of rigidity. This is just to show what resting tremors look like. Though it is a representation of the hand, the same resting tremors may be in any parts of the body, including neck or lower limbs. Gait, as I mentioned, most of the time patients with Parkinson's disease will move slowly and will lift the foot very little off the ground, what is called shuffling gait, and subsequently there will be forward flexion of the trunk, what is called a flexed posture. That is also quite characteristic of Parkinsonism. And subsequently, this flexed posture while walking or standing may be so severe the person will not be able to stand erect, will tend to fall. But this bending is not because of some fixed deformity of the spine. If this person lies in the bed, person will be able to keep the back straight. But while standing, the person will be in this flexed posture. So when it is extreme, it may be like this. Or it is also called camptocormia. So this is postural abnormality. Normally the person can walk without falling, but as the postural reflexes are lost, there will be tendency to fall. The person may fall forward, patient may fall even backward also. So besides these manifestations which are motor in nature, there may be less often seen motor manifestations, like the facial expressions. Normally the patient every normal individual will have some expression on the face, and you can find out person is angry or patient is happy or etc. But in case of Parkinson's disease, these features may disappear and the person face may look flat, also called masked faces or hypomania. And the blinking rate will be reduced in patients of Parkinsonism. And similarly, there will be slowness of movement of the finger while writing, also called micrography, or the size of the letters will become progressively small. And if we keep a record and you compare the handwriting of the patient on follow-up, you will see the number of the size of the letter, whatever the patient writes, will keep on decreasing in size. Freezing may occur, but these things occur in later part of the illness. And the patient may have very soft voice. Dysphagia or bulbar function will occur in the later part of illness after many years. So this type of brain stem dysfunction or bulbar dysfunction is not seen in early phase of Parkinson's disease. They are seen in the later part of course of the disease. So this is just a representation of what I have already said. Patient may have some facial abnormalities, no expression may not be there, and voice may be soft, etc. So beside motor manifestation, there may be other manifestations called non-motor manifestations. Like patient may have some abnormality of the higher mental functions or dementia. But again, these features will come in the later part after many years of Parkinson's disease. They should not be visible or there in the clinical picture of the patient in first few years. If they are present in the first few years of the course of Parkinson's disease, we should doubt the diagnosis of Parkinson's disease. Then patient may have other abnormalities also. There may be some dysfunction of the cranial nerves resulting in anosmia. Sensory manifestations are quite common, but they are more of subjective type. Patient may have various aches and pains in the limbs or at the back, which may be because of hypertonia. And the patient may have some neuropsychiatric manifestations that may result in some behavioral abnormalities or mood disorders. There may be some dysfunction in the sleep also, and the later part there may be dysfunction of the autonomic nervous system. And once the autonomic nervous system gets affected, then patient may have various autonomic abnormalities related to various organs in the body. It may be related to cardiovascular system or urinary bladder system or bowel system or skin. So these manifestations are usually seen in the later part of the disease course of Parkinson's disease. So as I mentioned, once the autonomic disturbance comes, usually will be seen after many years in Parkinson's disease, but in Parkinsonism plus they are seen early. So in a typical case of Parkinson's disease, autonomic dysfunction or cognitive dysfunctions come later. So they may be related to cardiovascular system, hypertension may be there, some genitourinary abnormality may be there, sexual dysfunction may be there, or GI manifestations may be there. But again, these things should come after many years after the onset of the manifestations of Parkinson's disease. So if a patient has got Parkinson's disease, so based on clinical manifestations, we can grade or stage the disease, how severe it is, how much is the physical disability because of the Parkinson's disease. So how do we do the staging? So basically it is the Hoehn or Yahr classification is there, and it is classified into 5 different severity scale from stage 1 to stage 5. Basically it represents a spectrum from minimal neurological dysfunction to bedridden state. So in stage 1, the patient will have manifestation of Parkinson's disease, and it is unilateral. As I mentioned, Parkinson's disease will have manifestations which are asymmetrical. So whenever there is unilateral involvement and with minimal and no functional abnormality. So patient may have some hypertonia, some tremor may be there, but person is able to carry out his normal social or occupational activity, then it is stage 1. When there is involvement of both the sides of the body, then it becomes stage 2, and still the postural reflexes will not be lost. The while walking, turning, etc., getting up from the sitting position, etc., person will not fall. But there is bilateral involvement. Then it is called stage 2. So when the patient has got stage 2 and some postural abnormalities are coming, or some neuropsychiatric manifestations are coming, then it is called stage 3. So when there is some postural problem, while turning, while getting up, some little problem is coming, then it becomes stage 3. In stage 4, the patient will have more postural abnormalities, so it will lead to tendency to fall. So to prevent the fall, patient will need the help of something. It may be a walking stick, it may be some walker, etc., to prevent fall due to loss of postural reflexes. And later on the disease may be so severe the person will not be able to stand at all, so the patient will be bedridden. That is stage 5. So this is just to show the graphic way. In stage 1 there is unilateral involvement and a person can carry out routine activities, and with progression it will progress from it will become bilateral, then there will be little postural abnormality, then there will be more postural abnormalities, tendency to fall, need to carry some stick or walker, and later on it may be wheelchair bound or bedridden bound in stage 5. So when a patient has got Parkinsonism, like there is hypertonia is there or slowness of movement is there, what does it mean? Does it mean that patient has got Parkinson's disease, or patient has got Parkinsonism because of some other reason? So that for that you will require history and examination of the patient. So when a patient has got Parkinsonism, as I mentioned previously, Parkinsonism means some tremor, resting tremors, hypertonia, bradykinesia, etc. So it may be because of no etiology and manifestation only limited to basal ganglia. That is called Parkinson's disease. When the patient has got Parkinsonism and also has got some involvement of other parts of the brain like cerebellar dysfunction, brainstem dysfunction, or higher mental dysfunction, then it is called atypical Parkinsonism or MSA, multisystem atrophy. Sometimes patient has got Parkinsonism and there is an etiology from outside. It may be because of drugs, like psychiatric manifest for very psychiatric illnesses, drugs are given, or sometimes antiemetics are given, or sometimes because of repeated trauma to the head, or patient may be taking some other drugs, or patient may have been exposed to some pesticides. Then there is an etiology, so it is called secondary Parkinsonism. Or sometimes Parkinsonism was not the primary problem. Primary problem was neurodegeneration elsewhere in the brain, and subsequently there was involvement of the basal ganglia. Then it is part of the other neurodegenerative disorders. So Parkinsonism, you should further clarify from the history and examination whether it is exclusive basal ganglia involvement or basal ganglia and other parts of the brain, or there is some etiology or not. So as I mentioned, secondary Parkinsonism means when there is an etiology. Etiology may be with drugs, like for psychiatric illness some drugs are given, for anti-emetic drugs are given. So that may cause dysfunction of the basal ganglia. So then it is secondary. Sometimes a tumor may affect the basal ganglia and cause dysfunction. Sometimes encephalitis can affect the basal ganglia. So similarly, if there is a stroke which is affecting the basal ganglia, it may be one stroke only, or multiple stroke may be there, multiple especially ischemic stroke that may cause dysfunction of the basal ganglia. So that can also result in Parkinsonism. So again, it is because of an etiology, so it is secondary Parkinsonism. And these are the other conditions which can cause dysfunction of the basal ganglia, and it is because of some etiology, so it is called secondary Parkinsonism. So in a patient who has got some Parkinsonism features, we should go into the details of the history and carry out proper detailed examination of the entire body, not just nervous system, to look for any evidence of liver failure, renal failure, or exposure to toxins, etc., and then make the diagnosis whether it is primary Parkinsonism or secondary or Parkinsonism plus. So if a patient has got bradykinesia or rigidity, it may be Parkinson disease, or it may be other type of Parkinsonism which I have mentioned. It may be secondary Parkinsonism, it may be Parkinsonism plus, or multisystem atrophy. So when should we say that it doesn't look like Parkinson disease? It doesn't look like Parkinsonism because of primary involvement of the basal ganglia without any non-etiology. So for that we have to look into the history of the patient and clinical profile of the patient. And if you find certain features, then you should think that it is not Parkinson disease, but it is Parkinsonism because of something else. So what are those red flags in the diagnosis of Parkinson disease? So if you have any of these, then you should think that it is not Parkinson disease, but patient has got basal ganglia involvement as a part of some other illness. It may be widespread degeneration, it may be some drugs, it may be some infection, etc. So whenever there is early involvement of the higher mental functions, dementia, or if the patient has got bilateral symmetrical clinical features, if there is early involvement of the bulbar functions, like there is a dysarthria is there, dysphagia is there, then again it is not Parkinson disease. If there is early postural loss because of loss of postural reflex, again it doesn't happen in the Parkinson disease. Usually these manifestations will be seen after many years. So if there is early involvement of the autonomic nervous system, and if there is other cortical manifestations like apraxia, etc. So early higher mental function, early autonomic problems, early cortical problems, early bulbar functions, early postural reflex abnormalities, you should doubt the diagnosis of Parkinson disease and think of some other kind of Parkinsonism like Parkinsonism plus or multisystem atrophy. So etiology, as I mentioned, Parkinson disease does not have any etiology, only then we make the diagnosis of Parkinson disease. So most of the cases are sporadic. In some cases, there may be some association with some environmental factors, especially those people who are above 50 years of age. So it may be seen because of association with some pesticides, and more often the Parkinson disease is seen in rural areas compared to urban areas, and also those people who consume or drink well water. But there is a reverse association with Parkinson disease. So those people who smoke or have coffee, they are less likely to develop Parkinson's disease. So they are just some environmental factors which may have some relation with the development of Parkinson's disease. So as I mentioned, atypical Parkinsonism, it is also called Parkinsonism plus, which means there is dysfunction of the basal ganglia and it is associated with dysfunction of other parts of the brain. Like there will be cerebellar dysfunction, or there may be some brainstem dysfunction, or patient may have some cortical problems or corticobasal ganglionic degeneration. So all these constitute atypical Parkinsonism. So when the patient has got Parkinsonism with cerebellar problem, which may be predominantly cerebellar or predominantly Parkinson with minimal cerebellar, then it is called MSA or multisystem atrophy. So atypical Parkinsonism, as I mentioned, there is involvement not just of basal ganglia but elsewhere in the central nervous system. So there is widespread neurodegeneration. It can affect the cerebellum, it can affect the cortex of the frontal lobe, temporal lobe, it may affect the basal brainstem, etc. So then it results in manifestations resulting from dysfunction of multiple parts of the brain. Then it's called atypical Parkinsonism. So the clinical manifestation will be Parkinsonism plus additional manifestations will also be there. And in this type of Parkinsonism, there is a very rapid progression of the disease. It has got very aggressive course. Within few years, the patient will have a rapidly downhill course and will succumb to the illness. So there will be early cortical manifestations, early speech abnormalities, early gait abnormalities, etc. in atypical Parkinsonism. So this type of Parkinsonism may occur because of etiology, as I mentioned, or some from outside. It may be some inherited disorders, etc. Like it may be because of Wilson disease. Wilson disease can cause dysfunction of the brainstem and also the basal ganglia, resulting in Parkinsonism. And sometimes it may be other types of degenerative disorders like Huntington's disease, or there may be neurodegeneration of brain with iron accumulation. So there are different conditions which can have Parkinsonism as one of its multiple features. So in a patient with Parkinson's disease, we are restricting this discussion to Parkinson's disease. What are the investigations to be done? So in a typical case of Parkinson's disease, it's a basically clinical diagnosis. No investigations are required. No imaging is required. So only when you find that something unusual in the clinical picture of the patient or difficult cases, you can carry out the brain imaging to rule out secondary cause or atypical Parkinsonism. And if you do the imaging of the brain, especially this SPECT or PET examination of the brain, then you will find that there will be evidence of loss of dopaminergic neurons. So whichever part of the brain has got dopamine and dopaminergic neurons, those areas will show less uptake of the isotope. So if you other part is that, as I mentioned, the important structure which is involved in Parkinson's disease is the substantia nigra. Okay, if there is involvement, then this tail-like structure will be looking abnormal. So this is called swallowtail sign. So on MRI, if you do, there will be some abnormalities related to the substantia nigra called swallowtail sign. And if you do a radioisotope scan, this is the normal appearance. This is the area which contains dopaminergic neurons. If these neurons are there, they will take up the radioisotope and will be visible like this. But if these neurons are lost, then radioisotope uptake will be less and the picture may look like this. So there is a reduced uptake of the isotope because of loss of the dopaminergic neurons. Though these studies don't require routinely, but if you carry out, you will find evidence of loss of dopaminergic neurons. Again, genetic testing is not required in Parkinson's disease because most of the cases are sporadic, but in few cases it may be useful, especially those people where the Parkinson's disease has developed early in life. Whenever a patient has got Parkinson's disease under 40 years of age, we should look for any familial predisposition. So there is a gene called Parkin gene. So that may predispose family members for early development of the disease. So there may be mutation of other genes also like LRRK2 gene. So only in few cases, early involvement of the basal ganglia or if there is a family history of Parkinson's disease, then you can carry out the genetic test, otherwise not. So once we know that the patient has got Parkinson's disease, how do we go about the Parkinson's disease treatment? So whenever a patient has got disease, we should first find out how much is the disability. If the patient has got minimal involvement and the neurological deficit is minimal and person can carry out routine activities without any disability, treatment may not be given because there is no treatment to reverse the degeneration. So only when it is interfering with the functions of the individual or when the person is worried a lot, then you can start the pharmacological treatment. So there are different group of medicines which are used in the treatment of Parkinson's disease. The most commonly used drug is the Levodopa. It is always combined with carbidopa. Other group is Anticholinergic drugs. I'll come to them one by one. Or Dopamine Agonist, MAO Inhibitors, or CMT, catechol or methyl transferase inhibitors, and some other drugs used in those patients where usual drugs are not working. So if you look at the Levodopa, this drug is used most often in the treatment of the Parkinson disease. And it is so often used and it is so effective that if you have given this medicine to a patient with Parkinson disease and there is no response to the treatment, then you should doubt the diagnosis. Might be it is not a case of Parkinson disease but secondary Parkinsonism or atypical Parkinsonism. So it is so effective and so often used. But if levodopa is given alone, it may be metabolized in the peripheral tissues with the peripheral manifestation of the dopaminergic type. So to prevent peripheral metabolism of levodopa, it is always combined with decarboxylase inhibitor like carbidopa. So levodopa is combined with carbidopa, it is not given alone. And sometimes this combination of levodopa and carbidopa may not work adequately in spite of maximum dose, then another drug as COMT inhibitor can be combined with these two medicines. So depending upon the response, the dose is increased. If the maximum dose is also not working adequately, then you can add COMT inhibitor also. So but it has got its own manifestations. So though the manifestations are dopaminergic in the central nervous system, but peripheral manifestations will also be there to various extent. So patient may have various dopaminergic manifestations as side effect. Like patient may have some GI manifestations or cardiovascular manifestations, etc. So depending upon the side effect, you can titrate the dose of the levodopa or you can replace it with some other drug. So patient may have motor manifestations also. Patient may have dyskinesia as a side effect to levodopa, and subsequently it may the dose may be either reduced or it may have to be replaced. So when you are giving levodopa, most of the patients will respond to the drug. Sometimes you are giving drug, for example, 3 times a day, 8 hourly, and patient is having adequate response. But in some of these individuals, towards the end of the dose effect, the patient may have reappearance of symptoms. So instead of giving, it is called weaning off effect or weaning off effect. In that case, you can increase the number of doses per day. Instead of giving 3 times, you can make it 4 times. And manifestation maybe like dyskinesia, then you have to adjust the dose of the drug. Sometimes while you are giving levodopa, patient may have on and off period, which means when you are giving, sometimes the manifestations are coming, sometimes manifestations are suppressed with the medicines. So in this case, you have to see whether you have to increase the dose or you have to replace with some other medicines. Other group of medicine which is used in the treatment of Parkinson disease is the dopamine agonist. Two drugs are used very often, pramipexole or propranolol. I'll come to that again. So basically they are dopamine agonist, which means they increase the effect of dopamine at the local site. So basically they act as directly on the dopamine receptors. So whatever the manifestation because of dopamine loss, they are basically ameliorated with these agents. But these agents have got relatively less potent effect. So they are more often used as add-on therapy with levodopa. Or sometimes when the patient has got minimal manifestations and he is worried, he is anxious, and for minimal manifestations, instead of giving levodopa, you can give dopamine agonist. But most of the time, dopamine agonists are added to those individuals who are receiving levodopa, but the adequate response has not been achieved. So again, just like levodopa, these dopamine agonists may also have some dopaminergic side effects like nausea, vomiting, or orthostatic hypotension may come. And sometimes patient may have some neuropsychiatric manifestations like cognitive dysfunction, hallucinations may also come. Other group of drugs which are used in the treatment of Parkinson disease is the MAO inhibitors. The two drugs which are used are one is the selegiline, other is rasagiline. So what they basically do, they increase the concentration of the dopamine at the site where the dopamine neurons are less. They block the metabolism of dopamine, so the concentration will be high. So the manifestation because of deficiency of dopamine will be less. Again, just like dopamine agonists, their efficacy is basically less than levodopa. So again, most of the time they are added to the treatment when the patient is not responding adequately to levodopa carbidopa combination, or if the patient has got mild manifestations only and is requesting for treatment because of anxiety or he's worried, then you can give MAO inhibitors as the initial therapy. Other group of drugs which are used in the treatment of Parkinson disease is the COMT inhibitors, catechol-methyl transferase inhibitors, entacapone or tolcapone. So most of the time these drugs are given as add-on therapy to other medicines which are already going on. So not alone. So whenever a patient is receiving levodopa and carbidopa and adequate response has not been achieved, then you can add one of these COMT inhibitors to improve the response to treatment. Side effects again, they may just like other, they may have some nausea, vomiting, or dyskinesia type of manifestations as side effect. So one more group of drug which is used in the treatment of Parkinson disease is the anticholinergic drugs. More often it is the trihexyphenidyl or sometimes bezotropine. So they have got certain specific good effects, beneficial effects for the patient, especially the patients who have got significant tremors, which is interfering with the activity of the person, like while writing, etc., while eating, etc. So to reduce the tremors especially, you can use anticholinergic drugs, and it can be combined with other anti-Parkinson disease. But because when you use the anticholinergic drugs, it may cause certain unpleasant side effects. Especially it may cause urinary retention, or it may cause cognitive dysfunction. In elderly patient, cognitive dysfunction may be because of the age or because of some other neurodegeneration. In that case, giving anticholinergic drugs may be counterproductive. So you have to keep in mind this. If a patient has got cognitive dysfunction, then you have to avoid. If a patient has got some other autonomic manifestations, then you better either give less dose or use some other type of drugs. Other drug in the treatment of Parkinson disease is the Administered. Basically, it is an antiviral drug, and it acts through NMDA receptors. Again, it has got mild efficacy and mostly used as add-on therapy. So these are the various combinations which are used, like levodopa with carbidopa, or levodopa with carbidopa, and some COMT inhibitors like entacapone. So different strengths are available. Start with low dose, see the response. If the response is inadequate, keep on increasing the dose, go to the maximum. If it is not working, add entacapone. If that is not working, you can add some of the other type of drugs like dopamine agonist you can add, or MAO inhibitors you can add. So depending upon the response, or whether it is adequate or not, or side effects are coming or not, other drugs can be added or they can be eliminated. So as I mentioned, Parkinson disease is basically a degeneration of the neurons. Can we reverse this process? So far there is no medicines available which can reverse the degenerative activity in the brain, but you can decrease the pace at which the neurodegeneration is taking place. Various drugs have been used to decrease the rate of loss of dopaminergic neurons like CQ10 or pramipexole, rasagiline, etc. But the results have not been very consistent. So to label them as neuroprotective agents will be premature. But some people say they have got some neuroprotective properties, so they may be tried in early stage of the disease. But the results are not very encouraging. So if a patient has received all the medical treatment with maximum dose or side effects are coming, then still the patient has got significant manifestations, the next step may be surgical treatment. Surgical treatment most often used is the deep brain stimulation. So in that you basically stimulate part of the basal ganglia, especially the subthalamic nucleus and globus pallidus interna. So it will have some beneficial effect, especially the off time or dyskinesia type of manifestations of Parkinson's disease will decrease. So it is used in those patients who have been treated with a medical treatment and they have developed side effect or the response is inadequate. Then you can use deep brain stimulation. But this type of treatment will not help conditions like postural abnormalities or dementia or freezing. So other features like off-time manifestations or dyskinesia type of manifestations of Parkinson's disease can be managed with deep brain stimulation. Other drugs which are or treatment modalities which are in experimental stage are, one is the transplantation of fetal nigral cells or gene therapy or trophic therapy, but they have not been proven successful so far. So you can say they are only experimental treatment in Parkinson's disease. So this was about the treatment of the motor or non-dopaminergic features of the Parkinson's disease. Besides this, patient may have various other manifestations due to Parkinson's disease. So you have to treat those things also. Like patient may have cognitive dysfunction, patient may have autonomic dysfunction, etc. So you have to give treatment for that also. So if a patient has got dementia, so it will occur mostly in the later part of the disease. So you have to basically treat the patient as we treat dementia and any other patient. Most of the time the treatment will be supportive only. But you should keep in mind the drugs which are commonly used for Parkinson's disease that can worsen dementia. So then you have to either stop it or use other type of treatment. So treatment of dementia, again, drugs like anticholinergics or dopamine agonists, they are likely to worsen dementia. So better decrease the dose or avoid these drugs. Or use smallest dose possible in the treatment of Parkinson's disease. Otherwise, the higher mental functions or cognitive dysfunction will become more. The anticholinergic agent like donazepam may be used in the treatment of cognitive dysfunction. Sometimes the patient in the latter part of disease of Parkinson's disease can have various types of autonomic dysfunction that may be related to cardiovascular system like orthostatic hypotension, and it is treated on its merit just like any other patient of orthostatic hypotension. So whatever the etiology of orthostatic hypotension, the treatment remains the same: diet, salt, elevation of head, flutter of cortisol, etc. So with this, I come to the conclusion of this discussion. I hope it must have benefited you. And if you have got any queries, we can discuss once the college starts functioning, and you can have bedside discussion or interaction, or you can have any other type of uh, interaction about the examination of patient with Parkinson's disease. So with this, I close the session. Thank you for